Well, first of all, first of all, I'm so humbled. I mean, following Katie, I mean, you guys, like a lot of the studies she said, we're going through and like the changes in standard of care, she's actually led. For me, it's always a privilege to work with her and to have the opportunity to see the great work she's doing. The other thing I sort of wanted to highlight is, the doctors that you are speaking today, we're a team. In other areas of medicine, there's a lot of competition. We fight for patients. Kathleen and I were just a meeting together, as she alluded to, the European Society of Medical Oncology. Dr. Jazeera and I were at a meeting together 2 weeks ago. Dr. Gardner and I work closely in the GOG on some of the communications effort that she leads. Ursula Matalonis and I lead an endometrial cancer trial. So, we're a really team effort, which, for me, it takes a lot of stress away from what we do. We all have a common goal and to help women who suffer from these malignancies to do better, to live longer. And, I'm humbled and actually privileged to be able to work not only with this group, but more importantly, to give them the opportunity to treat our patients. The key to memory is repetition. I'm going to go through some of the information that Kathleen went through. Obviously, hers was a little bit leading edge, but when we set the table for ovarian cancer, we have to go through some of the basic information, which I want to go through. Maybe in some areas a little bit more in depth, but in other areas, just to highlight what she had already said. As mentioned, I'm in Miami Beach. As I said, there's equity amongst the GYN oncologists, but I work in the best city. I know there's a background, but I'm overlooking Miami Bay right now, so come down and visit. I'm a professor at Florida International University. So ovarian cancer, we went through some of these numbers, but it's important to know the incidence is over 20,000 cases per year. Most women are diagnosed with advanced stage disease. So when we talk about it being the most deadly of gynecologic cancers, and I use that word seriously, right? We're here because we want to prevent a bad outcome. The reason really is because there's no early detection test, there's no early screening test that's really ready for prime time. Because of that, most women are advanced with stage 3 or 4 disease. And then because of that, being advanced disease, it's more difficult to treat. 5-year survival is 38%. It's getting better. Again, a lot of it's based on some of the great work by Dr. Moore and others. And the 5-year survival for advanced stage disease is 20 to 30%. Ovarian and early stage disease survival is about 90%. So that's what I'm saying. Even if there's early detection, not only screening, it'll help us in the long run. Ovarian cancer most frequently affects women older than 45 years of age. The median age of diagnosis is 63. Median age of death due to ovarian cancer is 70, much, much too young. The work that Kathleen highlighted with Parp inhibitors and some of the other work that Ginger is going to talk about with surgery and Amir with immunotherapy, that we're hoping to change that. We could see the age of distribution here. And, we need to, these are our mothers, these are our grandmothers, these are our neighbors. We need to get better in treating them. As I go forward, I'll talk about the patients who are affected with hereditary cancers, the BRCA1s, BRCA2s. A lot of this is what we know about, and their age of diagnosis. A lot of time in the BRCA patients, it can be a little bit younger, but you could see here, it's still, in the 50s that most of these cases occur. One of the nice things is we are seeing, this slide's a little bit old, but we are seeing epidemiological data showing a trend towards a decline in ovarian cancer incidence mortality. Ovarian cancer incidence has declined by almost 2%, while deaths due to this disease has also declined less than 2%. I want to highlight here, as mentioned earlier, I'm a leader in uterine cancer for the GOG. We need to not only focus on ovarian cancer, which this group does a phenomenal job in doing, but we also need to focus on other gynecologic cancers as well. Oftentimes, endometrial cancer and ovarian cancer go hand in hand. And what we're seeing in endometrial cancer is an increased rate of deaths due to the disease, to the point that it's probably going to be equal, if not surpass that of ovarian cancer. But right now, obviously, we're focused on ovarian cancer, and we need to do better in all of our diseases. Ovarian cancer mortality has remained mostly stable. We've seen a decrease in breast cancer, but the stability in ovarian cancer, maybe a slight decrease. But, again, the common theme here is we need to do better. And the group of docs that I'm, humbled enough to present to you with today, we're all, we're committed to doing better for our patients. Incidence and mortality rates are highest in white women. It is a disease that is more likely affected in white women, and we could see the numbers here. The top 4 areas, white, Black, Asian, and American Indian, those go through race, Hispanic and non-Hispanic ethnicity, but the highest numbers are in white women and the highest numbers of death as well. But again, we need to not only, we're in the age of appropriately diversity, equity, and inclusion. We need to make sure that we identify differences in the disease by race, by ethnicity, in order to best treat those patients due to this disease. So what do I mean by that? Sometimes ovarian cancers can be the same across races, but sometimes they could be different. With that, they could have different prognoses. They could also have different treatment options. So more and more, and the federal government is recognizing this, the FDA has guidelines for this. Other organizations are leading this as well. But more and more, we're not only focusing on the disease. Dr. Moore said earlier that we're breaking the disease down by different histologic subtypes that we are. But we also need to break the disease down by the women that are getting affected by them, by race, by ethnicity, to come up with better treatment options. Ovarian cancers, there are different types. The most common type is the epithelial ovarian cancer. That's the typical type that we always think about when we talk about the 50-plus-year-old woman who's getting ovarian cancer. We do see other types, germ cell tumors, stromal carcinomas, stromal cancers. The bad news is they're cancers. The good news is the outcome on those are much, much improved, even to the effect that we have, they affect younger women that we're doing well with fertility sparing and things like that. Malignant germ cell tumors account for 5% of ovarian cancers. These are, again, the younger patients, not necessarily the typical ovarian cancer in the older patients. We talked about fertility preservation. Median age here is 19. Treatment, fertility preservation, leave in the uterus, leave in the other ovary. It's okay to remove one ovary. That still maintains fertility. And fortunately, in those advanced stages that do need chemotherapy, it is a disease that's very, 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 very sensitive to chemotherapy. So the likelihood is that it's going to work. The epithelial ovarian cancer is the most common. We also need to differentiate them not only by being epithelial, okay, but the subtypes in the epithelial. The typical high-grade serous carcinomas, these are the most common. These are the ones that are really most amenable to the PARP therapy that Dr. Moore was alluding to. Low-grade serous ovarian cancers is one of the areas of interest that I have. It actually, believe it or not, it actually acts more like a breast cancer. And we're finding out on a daily level that we're treating these patients with the same regimens we're using for breast cancer, not for ovarian cancer, and patients are doing better with these hormonal-based regimens. Clear cell carcinomas, a less common subtype, as well as endometrioid carcinomas. We're actually now treating a lot of those the same. We're looking for some differences, and we need to do better there. And finally, mucinous carcinomas, which has some similarity actually to colorectal cancers, and studies have been done to sort of help delineate treatments for those different diseases. So what do I mean by delineate? I'm not going to go through this because I know this is a lot of science here, right? A lot of science, and sometimes we can't really memorize this. But the point of showing this slide is to show you that there's different mutations, different etiologies, different causes of cancer based on the different histologies. And we know more and more in this era of personalized medicine, personalized immunotherapy, personalized targeted therapy. The one drug that Dr. Moore mentioned earlier that we're hoping to hear from the FDA, mirvetuximab, it's going to be based on a certain overexpression of a protein, if it works or not. All ovarian cancers are not the same, and as the science progresses, we need to come up with different treatment options in order to best treat our patients and help them get the best prognosis. Risk factors, I want to just go through this quickly because a lot of this is information that we may have. Median age, we talked about 1 in 70 lifetime risk. Risk of getting ovarian cancer is 1.6%. A lot of times I get asked in my clinic, well, why not just take out ovaries in everyone? 1.6%, believe it or not, there's also a risk of surgery, a risk of complications for surgery, and needing unnecessary surgery. So at this point, we'll do prophylactic oophorectomies in those women at high risk, I'll talk about that shortly. But we're not doing other type of prophylactic surgery. 10 to 15% are hereditary. Breast cancer, 2 to 4 time increase in risk of ovarian cancer. Nulliparity, never giving birth. We're not sure if it's the infertility itself or just not having children, but that increased the risks of ovarian cancer. Fertility drugs, this was a controversial issue about 15, 20 years ago. Probably not as related as much. And then as far as decreasing risk, breastfeeding decreases the risk of ovarian cancer. Oral contraceptives also decrease the risk of getting ovarian cancer. Obesity, we're knowing more and more that obesity is an epidemic. It's a pandemic in this country. We need to do better. When we compare the rates of obesity in the US compared to rates of obesity in the other countries, we're not doing so great. Part of that's because we have a bunch of McDonald's and Burger Kings on most corners, which we need to hopefully drive by and not eat so much of the fast foods and come up with healthier options. But obesity can enhance ovarian cancer risk through a hormonal mechanism. Fat cells produce estrogen. Higher levels of estrogen can drive estrogen-dependent tumors, and a subset of ovarian cancers are estrogen sensitive. We sort of talked about, when we talk about mutations, I like to show this slide because mutations are divided into germline, also known as hereditary. So all cancers have mutations, every single one of them. When I talk about the germline mutations or hereditary, that's the 10 to 15% that we're talking about. Somatic mutations happen later on in life, after conception, and these cause cancer and or other diseases. Again, germline, hereditary, born with it, 10 to 15%. Ability for prophylaxis and risk reduction. Somatic cancers, what I tell my patients, it's sort of bad luck. And we need to do better to identify what these mutations are and hopefully prevent them. How much is hereditary here? I said it earlier, 15%, some studies say up to 25%, are due to gene changes that are inherited from a person's parents. Here's how it works. Your mom has a gene or your dad has a gene, not both. Every gene is given to the offspring and only one of them is active. So if you get the gene from your mom and she has a mutation, then you become BRCA positive, for example. If your mom's BRCA positive, but then you get the active gene from your dad, then you're in the clear and you're not at increased risk. We don't know this unless we did genetic testing. As far as the hereditary syndromes that we look for, BRCA1, BRCA2, another thing called, we call it Lynch syndrome now, hereditary non-polypulses colorectal cancer syndrome. We know that these could cause up to 7, in these patients, up to 7 to 10% can have ovarian cancers. This is very important. This is something that changed over the last 5 to 10 years. And Dr. Moore said it, I'm going to say it again. All women with ovarian cancer, fallopian tube, or peritoneal cancer should undergo genetic testing. We do this for really 2 reasons. One, to help identify other family members who may be at risk for this disease and to intervene depending on their age and their risk of cancer. And secondly, again, a lot of this is based on the great work of Dr. Moore and others to determine which patients will be best suited for therapy with PARP inhibitors. If a mutation is detected, family members should undergo testing. Prevention is the best method to prevent ovarian cancer. In the past, it was tough to get. Our insurance companies to approve it. Now they've realized that it's better to prevent a cancer, cheaper to prevent a cancer than to treat a cancer. BRCA-associated cancers actually have an overall better prognosis. I just want to show you that here, and a lot of it's due to the biology of the disease, but now more and more the treatments that are available. We talked about risk reduction with oral contraceptives. In the patients who have a BRCA mutation, as I alluded to earlier, once they reach the age of 35 or they've completed childbearing, they're at risk for risk reduction surgery. It's important in this risk reduction surgery not only to remove the ovary, but remove the fallopian tube as well, as there's newer data to suggest that all ovarian cancers, or at least a subset of them, arise from the fallopian tube. So we want to remove both. We also do this risk reduction surgery in women with Lynch syndrome. In those women, it's not only ovarian cancer, but uterine cancer as well. So those women will do a hysterectomy as well as bilateral salpingo ovarectomy or removal of tubes and ovaries. We talked about most ovarian cancers are advanced at the time of diagnosis. A list of symptoms here. They're non-specific. Pelvic abdominal pain or back pain, bloating. Women complain that their pants are fitting tighter than usual. They feel pregnant. Difficulty in eating, urinary urgency, fatigue, indigestion, constipation. A classic symptom that I see is increase in abdominal girth, or the belly is getting bigger with a weight loss. Sometimes that's associated with ovarian cancer. We could even see a cough. Sometimes cough, there's fluid in the lungs from ovarian cancer. That could be the presenting symptom. We as a group of gynecologic oncologists need to do a better job in teaching our colleagues about best ways to identify these symptoms and to treat them moving forward. Surgery is once diagnosed, and I want to go through some of this quickly, but surgery is a primary treatment for staging and debulking. We're doing more and more chemotherapy first, and I'll talk about that in a minute. Stage 1 disease and 1A, 1B, in those desiring fertility, a unilateral tube and ovary, comprehensive surgical staging, which includes lymph nodes. We're doing more and more of these minimally invasive with robotic technology. In those not desiring fertility or those with stage 3 or 4 disease, actually, the treatment is a hysterectomy and what we call debulking, or getting rid of as much tumor as we can see. In the patients who we can get rid of all the visible tumor, they have a better outcome than those patients that we can't get rid of all the tumor. This is the early stage staging for this. I know we're a couple minutes behind oophorectomy and comprehensive staging. We do the comprehensive staging because a third of these patients will have more advanced stage disease histologically or not visible to the eye. What I was alluding to earlier is as far as neoadjuvant chemotherapy. As mentioned, the most important part of the first surgery is to in fact get rid of all the cancer. Given the spread of this disease, sometimes sometimes we can't get rid of all the tumor at the time of the original surgery. So what we're practicing more and more is something called the chemical debulking or neoadjuvant chemotherapy, giving chemotherapy first, followed by surgery. And what this yields is a sort of a simpler surgery, less risk of complications, but also a higher risk of getting disease down where it's not visible. And again, as mentioned for the third time, it's those patients that you can get down to the disease that you can't see that have better long-term outcome. Systemic. So the first step is surgery. Neoadjuvant, we give chemotherapy first versus surgery. Adjuvant chemotherapy is usually given to improve outcomes. Even in the early stage disease, grade 3 disease, we like to give 3 to 6 cycles of IV platinum-based chemotherapy. Lately, it's called IV carboplatin and paclitaxel. Stage 2 to 4 disease also need platinum-based chemotherapy. Paclitaxel and carboplatin is considered a standard frontline chemotherapy regimen. This is based on the first line, a series of articles as shown here. And Dr. Moore really did a nice job in going through this. We're learning more and more that maintenance therapy or keeping patients on a treatment can help portend a better prognosis. We've been studying this for a long time. Pazopanib maintenance therapy didn't work. Paclitaxel, a study that we did about 20 years ago, showed that it could decrease the time to recurrence. However, it didn't affect overall survival. And more importantly, and if there's patients on here who've had it, it increases the time on paclitaxel or Taxol for 9 months. And as we know, that's prolonging a therapy with a fair amount of symptoms. What I tell my patients is, if you keep patients on paclitaxel, it'll take them a lot longer for their hair to grow back. But I also tell them that my hair is never going to grow back. So that was a joke. But so they're in good shape. But we moved away from paclitaxel. Bevacizumab, Dr. Moore went through quickly or extensively, and it does help to keep the disease away longer. Parp inhibitors are game changers. Solo-1, it was data presented last week by Dr. Moore and her team, showed that 7-year outcomes, patients are living longer, and we're getting to a subset of women who are treated, not just maintained, but treated from their ovarian cancer. Other PARP inhibitors shown in PALA-1, Prima, niraparib, rucaparib. These rucaparib, niraparib, and olaparib are the 3 FDA approvals in this area. We're using them quite often to help maintain and keep the disease away longer. We look out for drug reactions, but as you know, if you're receiving chemotherapy, the nurses talked about this in length. What do we do for follow-up? What I'd say is the first year, once every 3 months, second year, once every 4 months. twice a year thereafter. If there's we do a CA-125 every visit. Elevation of CA-125 stimulates us to get a marker, a tumor marker. Elevation of CA-125 stimulates us to get a radiologic test. Sorry about that. And the radiologic test determines if there's disease recurrence or not. What I tell my patients with elevated CA-125, no one in the history of the world ever died or got sick from an elevated CA-125. All it does is tell us that we need to get an imaging to see if anything's there or not. It may suggest there's disease there, but until we get the image that shows disease, we're in the clear. Signs of recurrence similar to the signs of initial diagnosis: pelvic pain, obstruction, decreased appetite, fatigue, early fullness, and as mentioned, the elevated CA-125. Survivorship. The institution of medicine defines survivorship care as beginning at the completion of primary care treatment. Here's a sort of a diagram of how we mention it. Starting on the left, diagnosis and staging, treatment with intent to cure. After treatment, manage chronic or intermittent disease, focusing on cancer-free survival, following for progression on treatment. Unfortunately, after survivorship, a percentage will recur, and then we need to refocus on palliative care treatment options, recurrent treatment options, and ultimately end-of-life care, which is something that we're all obviously very scared about, but it's something that we include in our complete management in the care for these patients. When they recur, a lot of patients are still chemosensitive. Treatment options there are still platinum-based therapies. I didn't want to go into the chemotherapy, platinum-resistant therapies. Again, Dr. Moore went through that extensively, and we're going to learn more from Dr. Jaziri about the immunotherapy possibilities. 4 essential components of survivorship: detection, surveillance, prevention, coordination, and intervention as needed. Adherence to survivorship: primary surveillance increases clinical detection, decreases morbidity. The earlier you find disease, the better. It can improve survival outcomes, and it's more cost-effective practices. That's what I have. I think I went a couple minutes over. This is my shop in Miami Beach. I sort of highlighted right on Miami Bay. But thank you very much for your attention. I think I want to thank the Ovarcom group for inviting me. You have a great organization focusing on patient advocacy. So again, it was humbling to be invited, and I look forward to future events like this. Thank you.